Hello, my name is Michael Downs and I'm an emergency medicine physician. Today we are going to be talking about calcium chloride and its use in the setting of hyperkalemia and end-stage renal disease patients. Calcium chloride is not new to your medication list and is something that you use commonly, but we have updated the policy and protocol handbook for ISOMA and have included it to be used in patients with concerning EKGs that are in a peri-arrest situation through a base hospital order. So let's talk about end-stage renal disease. End-stage renal disease is a diagnosis where typically your patient's kidneys no longer function to sustain life. Those with end-stage renal disease are at risk of becoming fluid overloaded, have high blood pressure, and go into cardiac arrhythmias that could be fatal for the patient. So it is important that when we are interacting with our patients, we are able to identify a patient that may have end-stage renal disease. One way you can identify this is just simply by asking them. Another way is by looking for an AV fistula or AV graft that may be in their extremities, looking for a port on their chest, looking for a peritoneal dialysis catheter in their abdomen. Some of the complications and signs of end-stage renal disease typically are peripheral or pulmonary edema. Associated with this, the patient could be hypertensive, or EKG changes. So potassium is very important and plays a very key role in the function of our cardiac myocytes and in the contraction of our heart. Potassium and sodium are exchanged via potassium-sodium ATPase pumps, and these two electrolytes help to create a concentration gradient and establish a resting membrane potential. When you have too much potassium in the extracellular compartment, this throws this whole system off and causes the resting membrane potential to become less negative, and also decreases the action potential. This then causes a slowing of impulse conduction through the myocardium and a prolongation of membrane depolarization. As a result, the QRS duration is prolonged, and this causes decreased myocardium activity, depresses the conducting tissues, which then leads to bradycardia and potentially lethal conduction blocks. So let's briefly go over some of the EKG changes we can see in hyperkalemia. The first change you'll see typically in hyperkalemia are peaked T waves. The next sign you'll see would be P wave widening or flattening and PR prolongation to the point where the P waves eventually disappear. And the last and most concerning sign of hyperkalemia in EKG is a sine wave, where you have QRS prolongation and bizarre QRS morphologies. You can also see high-grade AV blocks and bundle blocks, conduction blocks, and slow atrial fibrillation in patients with hyperkalemia. Eventually, patients will go into asystole if these arrhythmias are not quickly addressed. Currently, we use calcium chloride for patients that have gone into cardiac arrest suspected to be secondary to hyperkalemia in an end-stage renal disease patient, and in calcium channel and beta blocker overdose. Calcium chloride is also very effective in treating patients with hyperkalemia and stabilizing the cardiomyocytes in the heart. It helps by antagonizing the effects that potassium has on these cardiomyocytes and increases or raises the cell depolarization threshold. Calcium chloride does have very serious side effects. It should only be used when clinically indicated for the previous mentioned reasons. Some of the side effects from calcium chloride can be ventricular fibrillation, extravasation necrosis, abdominal pain, nausea, and vomiting. Rapid infusion has also been seen to precipitate bradycardia, and it should not be administered in the same infusion as a sodium bicarb at the same time. So, the change in policy reads as follows. For end-stage renal disease, patients on dialysis with suspected hyperkalemia and hemodynamic instability with documented sinus bradycardia, third-degree AV block, second-degree type 2 AV block, slow junctional and ventricular escape rhythms, or slow atrial fibrillation, through a base hospital order can be given as 1 gram via slow IV or IO push.